Day 2 of the ACC.11 and the I2 Summit is wrapping up in New Orleans, and starting now, we've got all the highlights you need to know. Welcome to CardioSource Video News. I'm Dr. Randy Martin. Thousands of cardiovascular specialists who want to be at the forefront of their profession are attending the meeting and learning from the late-breaking clinical trials as well as the scientific sessions. And to help you understand how to integrate these scientific findings into your practice, I'm joined by a very esteemed panel of experts. You're going to recognize Dr. Peter Block. Peter is Professor of Medicine and the Director of the Structural Heart Program at Emory University Hospital in Atlanta. Dr. Nalini Rajamannan is Associate Professor of Medicine at Northwestern University in Chicago and Previa Cardiology in Sheboygan, Wisconsin. And Dr. Tony DeMaria. Tony is Professor of Medicine at the University of California in San Diego, as well as the Editor-in-Chief of the Journal of the American College of Cardiology. So thanks for joining us. We had a good time this morning talking about some things, and I know that you're all well prepared now to talk about things. Peter, seriously, tell me about. There's a trial called the RAPS. Is that right? Tell me about that.
Yeah, the RAPS trial is actually an interesting trial. I'm going to do this. The radial artery as a free graft has always taken a bad rap. I don't know if you get that or not.
I got it. Thank you.
So the question is it really as bad as people thought? It turns out that after 7 years, the radial artery is really a pretty good conduit. There's a 10% better patency rate than over a saphenous vein bypass graft. And it is also interesting that the saphenous veins tend to have a lot more medial obstruction, whereas in the radial artery, that does not seem to occur. Bottom line, I think we need to rethink the free radial artery graft again for bypass grafting. Seems to be a good conduit, holds up for a long time.
Good. Tony, I know I'll come back to you in a second, Nalini, but Tony, there was another radial artery study that was looked at.
Well, right, and it was presented yesterday, and the question was radial artery catheterization superior to femoral artery catheterization? And that reflects the difference where radial arteries are not usually approached in the States, but are customarily approached outside the United States. And it was a study that basically showed that radial artery catheterization in the setting of an acute coronary syndrome for both angiography and intervention was essentially equal, so that really there was no specific differences between the two, but I think the advantages were in the unstated or unlooked at endpoint, like the ability to get up immediately,
right.
Less time on your back, less recovery time, things like that. And of course, a little less bleeding.
And less bleeding. Nalini, you could talk about any of those or any other topic that you like.
Well, I think readdressing the radial artery, again, 10 years later, it was big when I was a fellow, and now seeing it come back again is important. Having the muscular artery, having another option in addition to Lima, is going to be critical for bypass grafting. And I think the results from the rival study definitely demonstrate that there's no difference in the time in the cath lab. The bleeding risk was low, and that's going to be important, and of course all the other things that Dr. DeMaria mentions. So,
do you think it's going to change if we talk about the rival? Do you think it's going to change our practice? Because it's you say it's big in Europe.
Well, it is big in Europe. It's big in Canada. It's big in a lot of places, and it sounds as though everyone's now suddenly going to do radial artery catheterizations. I'm not so sure. I still worry about getting into trouble from the radial artery and not being able to bail out. Number one. You can always bail out from the groin, but I think the driving and compelling thing here is that 90% of patients said they'd rather have a repeat catheterization done from the arm rather than from the leg. And, patients drive what we do, and I think we need to think about doing more radial artery studies. For an intervention, I'm not sure it's always great.
Tony, you.
Well, I think it's reassuring that in this trial of ACS patients that, in fact, there were no greater incidence of major events, so that surely some of those patients required bailouts from things, and it was probably done reasonably effectively. I would say one of the questions I have relates to the radial artery conduit. And it wasn't compared to an internal memory, but it would seem to me that if you're in the chest to begin with, it'd be a whole lot easier to take down the internal memory and put it in than to go ahead and take out the radial artery. Has anyone looked at that?
No, these are not for Lima lads. This is for other.
These
this
are
is
other vessels.
So they all got, many of them got Lima lads, but the
Right.
question was if they needed a graft to a
second.
circumflex marginal or to
Would they
distal
use a
right,
radial?
which
Yeah,
was the correct one.
Nalini, I mean,
Yeah.
you mentioned that 10 years ago, and when you were in training, this was big. I mean, would
Yeah.
this influence? Would you ask the surgeon?
Oh,
Would
yeah.
you think about a radial graft if you need
Oh.
multiple grafts?
And especially, well, that or on the second time bypass grafting when they need a second surgery and
Right.
it's complicated patients. I think this is going to be a great option for them. And in terms of the radial access, I mean, I think what we need to have is experience. And so I think that's an important thing because if the interventionalist can do more of these, then it's an option in the future. It may
So
not be primary.
You agree with that?
Yeah, I
mean, is
agree with that.
That's
I'm not against this. I think it's a great way to take care of some patients, but
Okay.
I'm not sure for 100%. We shouldn't jump up and down and say everyone
everybody
needs
has
a
to
radial.
have it. Well, it'll be interesting to see. Now we're going to come back. We'll actually leave the radial artery and talk about something else in a minute. So we're going to take a short break, but don't go away. We're just getting started, and you'll hear from us in just a moment.
You're watching CardioSource video news coverage of ACC.11 and I2 Summit 2011.
Meet Brian, retired truck driver with repeat decompensated heart failure. He and his wife want to travel, but he's been admitted to the hospital again, this time with severe dyspnea. Follow Brian's journey from admissions to treatment and release from a hospital setting, and then to post-release care, with all the steps along the way aimed at reducing his chance of being readmitted. Experience the hospital-to-home learning destination. Hall D, number 3347, to learn about innovative technologies and solutions aimed at reducing hospital readmissions. Plus, hear from leading experts in the field and learn how they're implementing new processes to reduce readmissions in the H2H theater.
Well, immediately what we noticed is patients telling us that they really preferred the radial approach. When we first started doing this, they came to us expecting that we would be doing this via the femoral approach. They came expecting a prolonged bed rest time. They even warned us. They said, look, I've got a lot of back problems. I'm going to have trouble laying flat. And when we started doing it from the wrist and they were able to get up and ambulate right away, they were really thrilled.
Thanks for joining us again on CardioSource Video News. Now, our esteemed panelists were chewing on different topics there that we talked about the radial artery and stuff. Nalini, there's an interesting study called the REMEDIAL 2. Tell us a little bit about that.
Yeah, so this is a really interesting study comparing the standard of care N-acetylcysteine to looking at a closed-loop hydration system where you measure the urine output and then replace the fluid and also force diuresis with Lasix. And the goal is to try to see if they can reduce contrast-induced renal insufficiency. And they measured patients' serum creatinine levels, serum cystatin C levels, and they all demonstrate improvement. And then the cumulative endpoints were also improved, including death. So looks like an interesting system. It was a small study, and but it requires a Foley catheter and a few more things than what we normally use in our patients.
So it's designed to prevent contrast nephropathy. Peter,
Correct.
is this
You know, I'm not sure I quite get this study. It's a machine that fills you up as you empty yourself out. And it measures both ends and it keeps rotating fluids around. The interesting thing is, I think one of the outcomes was that there was almost 3 times the incidence of pulmonary edema, but in fact also 3 times less the incidence of need for dialysis. So there are some gives and takes on this. You know, just giving volume to patients to fill them up before you start is probably still the best way to take care of patients that have high creatinines before you do a heart cath. And I just believe in lots of volume before you get started, and that seems to do it. This is sort of a way to do that, but
yeah.
I'm not sure you need to spend the money for the machine.
Tony, what do you think?
Well, I think this focuses the importance of renal failure, or renal injury, I
Right.
should say, attendant to cardiac catheterization. I mean, it's a big problem. There's no question. In fact, we received a paper a while back that put a coronary sinus catheter in. The idea being that when you injected contrast in the coronary arteries, they would suck the contrast out of the coronary sinus. So people appreciate this is a serious problem. I must admit, this concept of giving a diuretic and fluid simultaneously seems like a long run for a short slide, but it's a big problem.
Okay. Peter, what about there's a trial called the RESOLUTE US?
RESOLUTE US is an interesting trial. This is the xaterolamus eluting stent, and we need to figure out whether or not this stent, we interventionalists, can ultimately be used in the United States. So this is a US trial, and it was an interesting trial in that it was done against historical outcomes. There was no randomization, as it were. So sort of a registry against history. Bottom line is the xaterolamus stent performed very well. Actually, it performed extremely well. And this now gives a ton of data on all kinds of fronts, including target lesion revascularization, target vessel revascularization, et cetera, stent thrombosis, all of which seem to be quite positive as far as xaterolamus is concerned. Good news, I think, for the RESOLUTE folks, and hopefully we will see this to be used in the United States shortly.
Tony, you have a take on this?
Well, I think stent technology is getting better and better. Now, there's a number of stents that haven't proven to be effective, but there are several on this program that have, and so I think that's good news in general, that we're getting better stents, more deliverable, and hopefully with less restenosis.
Super. You've been looking through your book down there. You have he has that mischievous grin on his face. But you've been looking at some of the other presentations. Tell me a little bit about those.
Well, we've been focusing on the clinical trials, but there's a number of other presentations that are of some interest. There was a study done that used coenzyme Q10, CoQ10, and in combination with garlic. And garlic's been around for a long time as a favorable agent. Done in firefighters, and they found that in the patients who received the garlic CoQ10 combo, that in fact there was less progression of coronary calcification, and there was a favorable effect on forearm vascular flow. So, antioxidant, add more garlic to dinner tonight.
And you'll be eating alone, but you'll be healthier. I was gonna say. No, that's very interesting. Nalini, what do you I know Tony's got another one, but are there things that went on today in the meeting that sort of struck you? I'll come back to you, Tony, because I want to ask you about one other.
I want to get back to those stent trials one more time, because I think that the RESOLUTE trial has one more thing that's important, is that as the drug biology in terms of the drug-eluting stents is evolving, this large trial is going to give us a lot of interesting understanding of re-endothelialization, the stenosis, and that balance between stenosis versus thrombosis. So I think as we're seeing these more of these stent trials come out, we're going to get better at it. We're going to have more options, but we're also going to understand what's going to happen in our patients a little bit better. So I think it's hard to get that large number, so it is going to be a nice foundation.
Excellent. Any closing comments about today's, or you want to mention another study?
Well, I participated in a session on Saturday that dealt with biomatrices for patients who are having acute myocardial infarction. I was very impressed. Dr. Doris Taylor was there, Karen Chrisman from UCSD, and they've developed these biomatrices that really represent ground substances, connective tissue material. And they seem to make an extraordinary difference in remodeling and in preserving left ventricular function. So I think we should keep an eye on that. That's some information that's coming out of this meeting that may prove to be really valuable in the future.
That's right. Well, that's great information from all of you. And I want you all to be sure to check in with CardioSource Video News as we roll through day 3 tomorrow of the ACC.11 and the I2 Summit. I'm Dr. Randy Martin, and thank you for joining us, and thank you guys and gals for joining us. It was a very good discussion.
Our pleasure.
Yeah, that's
So
good.
Thank you.
The